Welcome to this World Heart Federation cafe session, navigating the complexities of multiple long-term conditions. My name is Ami Banerjee. I am a consultant cardiologist and professor of clinical data science at University College London, and I also lead the Emerging Leaders Programme at World Heart Federation. It's my pleasure to have this illustrious panel with me today. From my left, I have Dr. Angela Koh, who is a consultant cardiologist and associate professor in Singapore, and also past emerging leader at World Heart Federation. I've got Professor Francisco Lopez Jimenez, who's division chair of preventive cardiology at Mayo Clinic, and will be, I'm sure, telling us lots about digital health and AI and many of the other things that he does clinical research in. To my right, I have my friend and colleague, Professor Kamlesh Kunti, who is a primary care practitioner, professor of primary care and vascular medicine in University of Leicester, but is largely famous for his cocktail making in the social media. And I've also got Mr. Stephen Macari from ABEC, representing the patient voice here today. He's based in Poitiers in France. So Kamlesh actually has a leadership role in multiple long-term conditions in the UK. Kamlesh, we've gone from single diseases to multi-morbidity, multiple long-term conditions. Can you give us a little bit of background about why that's happened and what's the global relevance of that?
So I think, first of all, if you don't take anything from this conference, this meeting, one thing to take home, let's not call it multimorbidity. People who have these complex diseases do not like being called multimorbid. They say, we're not morbid. So the term that's being now accepted is multiple long-term conditions. And the multiple long-term conditions has now become one of the fortes of management of chronic diseases because people, as you say, do not have one diseases. And just to give you an example, about 15% of people overall will have multiple long-term conditions. If you're over 60, 30 to 40% will have multiple long-term conditions. A multiple long-term condition is someone having more than one condition. The impact it has is that it has an effect on the person themselves in terms of their quality of life, their quantity of life, because they die earlier, and it's difficult to manage because there's so many conditions they have, the therapies they're using, multiple therapies they're using, and they contraindicate each other, and a lot of people have problems with adherence as well. And we are living longer now, but we're living in poorer health for longer because of multiple long-term conditions. And I think that's why there's this movement moving to multiple long-term conditions rather than working on single diseases. For example, someone might have 5 conditions. It's easy to have diabetes, cardiovascular disease, stroke, hypertension, hyperlipidemia. You're not going to go and see 5 different consultants. And rather than doing that, have a clinic that's more holistic to manage these patients.
So given your own expertise and all of the research you've done in diabetes, how has that changed the way you're practicing in this landscape of multiple long-term conditions?
So if you look at diabetes is the perfect example where it's the one disease that people have more multiple long-term conditions. So just to give an example, if someone has diabetes, only 15% of people with diabetes will not have another condition. 85% will have another condition. If you're age 65 and under, you'll have diabetes and 2.5 other conditions. If you're 65 and over, you will have diabetes and 5.5 other conditions. So diabetes is a multiple long-term conditions. And now in primary care, certainly for the past 8 to 10 years, what we do is we run a clinic, which is a multiple long-term conditions clinic. So if they've got diabetes, cardiovascular disease, hypertension, hyperlipidemia, and the other common condition with all of those cardiometabolics is depression. These people have a high prevalence of depression. So we manage them, instead of them coming for 15 minutes, 3 clinics, we have a 45-minute clinic appointment, holistic appointment. They get the same advice rather than seeing 3 people having different advices. We manage their mental health together as well. And the patients prefer this. You get less number of people not turning up, so DNAs, because they've got one appointment.
Thank you. Now, Stephen, if I may come to you next, what Kamlesh said last there, does that tally with your?
Yeah, he's basically said everything that's in my head about things. I have first of all heart failure due to a myocardial infarction, then sleep apnea, then diabetes. The diabetes has provoked other conditions. I'm not going to go into them, but basically is diabetes or the treatment for the diabetes, which I wasn't aware of. And I think one of the 2 points on having multiple long-term conditions is the fact that you have to manage these conditions quite often in isolation with the specialist. It's interesting what you're doing in the UK. In France, the practitioner, he doesn't have the same kind of status or ability. I'd love to go to one of these clinics because it's true that throughout the week I could be suffering more from heart failure because I'm tired. Other days it's the diabetes that's causing me problems. I have to go to the toilet X amount of times. And then other days I'm just like fed up. I'm depressed. And depression is one of the things that's not really dealt with in long-term illnesses in general. So everything Kamlesh has said is, it would be interesting to see that developed in other countries,
Now,
particularly France.
One of the terms that we hear and that's being used more in guidelines is integrated care. But from where you're looking, what does good look like when you are dealing with these multiple conditions and sometimes having to navigate through lots of different specialists and different allied health professionals?
Just a plug for the Heart Failure Policy Network. We wrote a handbook on multidisciplinary integrated care in 2018, and I think there has been very little or slow change in it.
Why do you think that is?
It's difficult to put. The theory is great, but it's difficult to put into practice, especially when you have a health service, for example, like France, where you have we have a private sector, but it's not private as in private in the UK where you pay for it. They're liberal. They work for themselves, cardiologists, diabetologists, anaesthetists, and we get reimbursed. But how do you coordinate all of these people who are not in the one care team? They are your care team. I'm quite fortunate that the cardiologist and the endocrinologist that I have, they're in the same office. They have a practice, and they communicate. It was the endocrinologist said, "I'm thinking about giving Mr. Macari SGL2 because he has diabetes, and that way you'll get reimbursed for it. What do you think in terms of heart failure?" That's fine, but that doesn't happen very often, And come back to this. I think we talked about this in June, and I was amazed in African countries how much emphasis is put on primary care clinics and community clinics.
And to be clear, you think that's a good thing?
Yeah, oh yeah.
Yeah, it's because I think it's difficult to see how people who have differentiated into specialties can really learn all of the different permutations and combinations of long-term diseases.
Yep.
I think we do need more
we need
more primary care and integration with primary care in order to make this work. Is that right?
Yeah, this has been a theme that in several heart cafes before we've done is we have to break down the silos or at least have a communication flow between them.
Thank you. I'm going to move over to Angela next, if I may. Angela, what's the view from Singapore on this topic? How big of a problem is multiple long-term conditions in the people who you see clinically, and how, if it is, then how well are you doing integrated care?
I think diabetes is a big problem. Data from the International Diabetes Federation estimates that half of the 500 million diabetics in the world, half of them actually reside in Western Pacific. and that's where Singapore is. So it is a big problem. What we've been trying to do in Singapore is to increase engagement between the GPs and the hospital clinicians. How that happens is we have basically case managers between the hospital as well as the GPs, and the case managers will communicate the patient's condition, the medical records, and then right side appropriate patients to the GPs. So that's on a very logistic and operational level. In addition to that, recognizing the importance of the medications, we've actually got a pharmacy on board. So we've got pharmacists who recognize which medications are subsidized, that means reimbursed more by the government versus those that are not, and apply the same level of assessing subsidies from the hospital right to the community. So that's important so that drugs don't get left out or there's continuation of care. And the third thing really is managing the medical records, because you don't want the GPs to be giving something that you don't know the patient is already taking, and then you get a lot of polypharmacy and drug interactions. So we do have a national medical record system. We call it the National Electronic Record Registry. It's real time. So if I prescribe something from the hospital, the GP in his office, there's a computer that's linked to this national record, and he can see what's going on. So at various levels, we're trying to increase communication in the management of patients with multiple long-term conditions.
In terms of the long-term conditions that overlap or that you need to see more integration in, are they the same ones that we're talking about here, or are there other diseases that in Singapore both you as a clinician and your patients are concerned with?
I think I would want to bring in one complication that our patients face. So for instance, in our department, we look at heart failure, but many times they often, because of diabetes, they have chronic kidney disease as well. And we work very closely with the renal department, more so recently because a lot of overlapping drugs. They are interested in giving their patients SGLT2 to retard CKD. For diabetes, the endocrinologist. So we're working a lot with them together. And for example, we know about the PREVENT calculator, which incorporates things like glomerular filtration rate, HbA1c, and so forth. And we're trying to put that into the national record system so that when somebody, for instance, either the GP, the endocrinologist, or the kidney doctor starts doing any calculations, patients are uniformly represented, and they know what kind of risk profile they have. So these are some of the things that we do.
Thank you. Now, Francisco, I know that you've got a lot of experience and expertise in digital health. Where do you think that can help us in doing some of this integration, both at the patient end and at your and my end as practitioners?
Yeah, well, the management of chronic multiple conditions becomes just so complex, and I believe we reach a point where it exceeds the level of complexity that the human brain can handle. And I think that's part of the problem when we deal with patients with multiple chronic conditions, because we tend to focus on one or two, many times the ones that we feel more comfortable with. But we miss many key opportunities to help. We miss a number of interactions of medications might have treating those patients, or how treating this problem might affect negatively this other condition, or the opposite, how treating this condition can actually help these other conditions.
Yeah.
And I think in that sense, it is extremely relevant to separate in a patient with multiple chronic conditions what is root cause and what are downstream conditions. And my area of clinical focus has traditionally been obesity and heart disease. And it's really impressive to see when you manage obesity, how many of the other conditions are either controlled. Some of the times they actually go away, and in many cases patients do better. So I believe that directing the focus on root cause problems and then subsequently on the downstream problems is key in the management of the chronic conditions. Certainly digital health is going to help us. I don't think it's the only solution, but it's going to be key for us to manage the high complexity that multiple conditions bring.
What do you think is its role? I'm talking about digital health in lower income settings, because often it's posed as a potential game changer. Do we have any basis to put that on?
No, I think that's an excellent question, because in reality, digital health can either amplify inequities in the world, because only rich countries and rich people in rich countries may have access to some sophisticated technology. By the other hand, digital health doesn't have to be expensive, and digital solutions are sometimes not necessarily extremely expensive. We know that more than half of the population have a cell phone, and wireless technology with applications can actually make a big impact in some conditions for self-management, for education, even for remote care. I think if there is something we learned from COVID is that we can actually do many great things doing digital health with low budget and actually make healthcare cheaper in some ways. So, but well, we have to be smart. It has to be planned. Equity implementing digital health will not just come as a result of the implementation. It has to be planned. It has to be part of the strategy.
Yeah, and we focus a lot at conferences on the medications and the medical side. When we think of multiple long-term conditions, how do we draw in the lifestyle management?
Oh, that's also a great question, because we tend to focus perhaps too much on medications, but certainly lifestyle is key for almost every single of those chronic conditions that we see. If we think, going back to the root cause problems, obesity as the root cause of many of the other problems, we know that the best approach is nutrition and physical activity. But the problem is that perhaps the implementation of lifestyle changes is not as simple as some people think. And the key there, in my opinion, is to empower patients to make those changes, because we believe that just teaching patients about how good exercise is enough. Well, every person in the planet knows that smoking is bad, but that doesn't mean that smoking went away, right? So people still do things that are not healthy. So knowing that something is bad is not enough. And I think that's where we clinicians generally stop. We tell patients exercise is good, but we don't empower people to become active. We have, millions of people extremely busy who get home at 5, 6 p.m., ready to get the children ready, get food, etc. So the implementation of lifestyle has to be part of our lives. In my opinion, the way how the world will become more physically active is not opening more gyms and fitness centers, is through the incorporation of physical activity through the day. We have to redesign offices. We have to redesign the work environment, schools, and therefore sitting gotta be a privilege of a few minutes every time, not necessarily what we look after during the whole day. And nutrition also has its own challenges. We have to focus on local, affordable, and also sustainable solutions. This idea of the Mediterranean diet is great for the Mediterranean region, right? But I'm pretty sure that in England, you have a lot of healthy options. Africa has a lot of healthy options, Latin America, Asia. So we have to focus on sustainable dietary patterns that patients can actually embrace.
I'm going to turn back to you, Kamlesh. So, given what Francisco is saying there, how I'm thinking that when we focus on multiple long-term conditions, how does that fit with the prevention agenda? Because by the time you've got multiple long-term conditions, to some extent, the horse has already bolted.
Yeah.
And is it taking our eye further away from, stopping these things happening?
So I'm going to take on three quick issues from what's been discussed. First of all, how do you manage these patients? And you mentioned about coordinating care. So there's not many randomized controlled trials of managing people with multiple long-term conditions. There's hardly any. The one decent one was a chap called Wayne Caton did that, randomized controlled trial of people with diabetes or cardiovascular disease and depression, published in New England Journal of Medicine, small trial. And basically they had care coordinators, like you said. They managed everything about those patients. And that led to improvements in outcomes, intermediate risk factors, and also depression. So really nice trial. In terms of AI, we mentioned, AI is working in low middle income countries. So if you look at Prabhakar and Nikhil Tandon, they've done a randomized controlled trial where they've had care coordinators go through villages and have an algorithm where they manage the patients, and the algorithm tells them what needs to be given to those patients. And that was a fantastic trial that was positive. And again, they've got lots of publications after that. In terms of lifestyle, that's the difficult one, Francisco, as he said. All the data shows, we've done the trials on it, all the data show it's fine for 12 months to 24 months. To maintain that for longer, there's not many trials that have done that. The only trials we know are working are the obesity-related drugs, therapies that have come in, GLP-1 receptor agonists, and we know you get substantial weight loss with that.
Yeah.
But long term, we're not sure, because when you lose weight, you lose 2/3 fat mass and 1/3 muscle mass. Whether that may have an impact longer term, we don't know. And that's why it's so important that whatever therapy we're giving them, even anti-obesity therapy, we need to ensure that person is still continuing with lifestyle to continue their muscle building. But maintaining lifestyle, we know, is difficult. And then, as you say, we need to put it into your normal environment. Gyms, I agree. Our gyms are fine at Christmas. We joined them for 3 months. And then after that, they stopped.
3 months is a long time for some of us. So
Several points.
Yeah.
In fact, a lot of points
before you move to what you were going to say, can I just pick up on something that Kamlesh said? Care coordinator. I guess that can be a lot of different people in a lot of different places. That could be relatives. That could be somebody in primary care. Could be in the hospital. What does that look like from where you stand?
From where I stand, it's very interesting, because the idea of case manager, patient navigator coming over from the state, from Canada, in particular from Quebec. In France, there is this open attitude to actually having patient experts working part-time in cardiology department, in oncology, in diabetes, to be the person who is at the center, who can direct the patient in the way that you do, and also coordinate his case study. I think it's an excellent idea. And I've been, in France, it's like, oh, patients, we can't pay them. And I'm like, why not? They're bringing a certain expertise. We now have university diplomas in being a patient expert patients. So why not? Some of the other things that are interesting as well, the data in France, we have this, I think the last 4 years, we've had this Mon Espace Santé, My Health space, which belongs to the patient. And it's an opt-out system, like organ donations. Everybody has it. If they don't want to use it, they have to sign an agreement saying they're opting out. Technically, any healthcare professional can look into my space and see what I've been prescribed, see what treatments I've had, etc. That's one thing. It's taking off, but a lot of times it's getting primary care practitioners to sign on is like, oh, it's just something else that we have to do. In terms of physical activity, in France, which is been an initiative over the last little while as well. I'm not standing up for France and saying it's the best example, but you can actually get physical activity on prescription. In other words, you get so many, right? Okay. I have been through the cardiac re-education, readaptation cycle, and I'm very much aware that like 90% of the people are like me. You do your 4 weeks, you come out for 6 months, you're great, and then after that, life gets in the way. So what I'm looking at personally for the association, and also trying to do a trial, we have innovative startups in France looking at tele-readaptation. And what I'd like to see is a follow-up from the care, the 12-month system, where patients are encouraged to do education, physical education, and they're followed up. Somebody's giving them a kick in the backside, saying, you didn't do what you planned to do this week. And that is a mixture of algorithms and also coaches. I'm very wary of, although I use wearables and all the rest of it, we have to be careful when you're talking about apps for patients, that they have to be simple, cheap, usable, and there's some kind of result, whether it's gamification or whatever. But don't ask the patient to continuously pump in data, because patients are people. We have lives. I've got more to do than check up on my health every 5 minutes.
Well said. You mentioned, Francisco, when you're talking about digital health, I just touched on inequalities. What are the kind of red flags, or the things that we need to be aware of, particularly maybe in the lower income settings, when we're thinking about using digital health solutions for multiple long-term conditions?
Yeah, for example, I think digital health solutions should not work only on this or that particular device, because that creates monopoly and control, and that obviously makes prices high. Gotta be interoperational across different platforms, different devices, and that would be one. So if it is not the case, then it's a red flag for something that is being inequitable. Other things might be, actually, the concept of inequality is important to keep in mind, that goes beyond the economic inequality, which is a big factor. But inequality applies also, particularly in patients with chronic conditions, to, for example, whether or not they are digitally savvy. They know how to use a device, right? Because then you have technology that can be used only by people who are 65 years or younger, right? Or just throwing up an age. It might relate to, for example, people with poor vision.
Yeah.
Are we limiting the applications only to things that you can see and nothing else for people who don't have a good vision, and so forth and so on? So I think when we talk about inequities, we have to think about, are we helping everybody across? And going back to the economic inequities, I think there are situations where health systems need to step in and be the ones implementing things. And also there is a concept of social responsibility or corporate social responsibility, where industries need to know that they may make money when they apply this in some regions of the world, but this has to come with some social benefit as well. So they can perhaps implement this in Sub-Saharan Africa and implement this at a very low cost, or in other regions of the world. But we have to be very alert of those red flags.
I think coupled with that, there is the idea of health literacy. Yeah. And given the world political situation, France, like the United Kingdom, there are a lot of immigrants who English or French is not their first language. So we have to be aware of adapting technology to that to that level, not making it complicated for one language or another.
Yeah. Thank you. In terms of technology, I know, Angela, you've got an interest in imaging and in multimodality imaging. How in the context of different long-term conditions, can the different imaging approaches or help us, or how should we be thinking differently about our pathways for investigation? Because we've talked about maybe when people have already got those conditions and need treatment. What about finding out about them in the first place?
Yeah. I think imaging has a role in detecting upstream asymptomatic subclinical disease before it's manifests in heart failure and acute myocardial infarction. We've learned a lot from imaging modalities such as positron emission tomography, PET. We've also learned a lot from CMR, so cardiac magnetic resonance imaging, in terms of imaging cardiac energetics and metabolism. So all of these actually have very similar and shared pathophysiological basis that links a lot of these metabolic conditions together before a manifest CVD or heart failure. So I think in that sense, imaging has a role, especially if we look at how the cardiovascular, kidney, and metabolic health progresses from stage 0, where there's no risk factors, and then stage 1, where there's just abdominal visceral obesity, and then stage 2, where you have hypertension and diabetes, and then stage 3, which is the subclinical CVD manifestation before stage 4, so it's full blown. So I think at stage 3, it's very useful to actually provide, imaging has the ability to provide an additional way to reclassify patients into those who probably will develop into full-blown disease in the future versus those who may not. So I think imaging has a role in doing that. On top of providing the biological mechanisms, for example, we've learned how SGLT2 inhibitors actually work, for instance, in patients with diabetes. So they have, by using PET techniques, they have reduced myocardial flow reserve, which is the total coronary macro and microvascular function. So I think imaging really has a role both in biology as well as in reclassification of patients.
Rather like the way we practice medicine, though, we're still quite disease or organ specific. So, you know, we do these scans in different places, different specialties. Is there a role for putting me through the donut and scanning everything?
I don't think there is evidence to say that, you know, we should have a scan if you are a certain risk group. However, I'm aware that, for instance, for calcium score, there are ongoing trials right now looking at whether calcium score can reclassify patients better. That's a matter of trials right now, and we don't have that verdict. But I think for patients who we feel that will benefit from some form of reclassification, either because of high family history of CVD, or they're just probably trying to convince them to even manage their blood pressure and take their medications for diabetes and take their medications for cholesterol, I think that might have a role.
For the UK, it's great for research, you know, cover scan work that you did during COVID and things, you know, multiple imaging and whole body imaging. You found lots of areas that COVID had affected, lots of organs. But in the UK, NICE has to make that decision to say, is this cost effective? So the Wilson-Younger criteria have to go all the way through. Is it going to do more harm to the patients? Is it going to be beneficial? And finally, is it going to be acceptable and cost effective?
Yeah.
So until you've got those trials, it would be difficult to put into a cost constrained environment.
Mm-hmm.
Yeah, there may be environments where people are paying for themselves. It may be acceptable, but in most healthcare settings, it wouldn't be acceptable now.
You mentioned earlier on, Kamlesh, that we've got very few trials in people based on multiple long-term conditions. How do you start when there's a fairly blank canvas? What's your wish list in the trial space?
Okay, so first of all, when I said there are a few trials, there are trials. So if you look at SGLT2 inhibitor, GLP-1 receptor agonists, they are preventing multiple long-term conditions. There are drug trials. If someone's got cardiovascular disease, it's going to prevent other conditions and diabetes. So there are the drug trials, but I wouldn't call that a traditional MLTC prevention management trial. So I think what you need to do is, I think, start with a blank slate, like the Wayne Catons. That was just diabetes and cardiovascular disease. Maybe have 2 or 3 conditions and depression, and then have a pragmatic trial which can be implemented easily. So have a few diseases together, then have a randomized controlled trial of care coordination, usual care versus care coordination for those conditions, and then look at the outcomes and the health economics of that. I think that would be the ideal trial for me.
Do you think there's so much in what you just said there that might be country specific, or even so variable around a particular country in different regions? How do we address the lack of evidence internationally when there's so much difference? It's hard enough just dealing with one disease, say heart failure. How are we going to do that?
All of these are areas that we can manage globally. The care coordinator in Singapore may be different to someone in France. The main thing is they get the same treatment. So they've got a quality assured program, how to manage those patients. If they have a heart failure, then need to ensure that they're on these therapies. It's coordinating the care to make sure they're on those therapies. They're taking them regularly, having a regular depression inventory to make sure to identify if they've got depression. If they've got depression, send them to a counseling team, send them to a general practitioner to start antidepressants if they're above a certain threshold. Diabetes, making sure they're having their HbA1c, blood pressure checked, everything regularly, which again, these are all things that are not done regularly because the patients are so complex. They've got so many things on their mind. They don't, even an annual check's not done on these patients. So it's doing those simple things well, and then coordinating and managing to ensure that they have all the treatments possible to improve the risk factors, including the depression. So it's basically you're doing a care coordination program to improve multiple risk factors for these patients. We're not talking about expensive therapies. The therapies we already have.
Thank you, Stephen. We've also, in the patient and public space and in the funding and charity space, been disease and organ specific. How, given the realities that we're talking about here of multiple long-term conditions, how do we motivate and mobilize those stakeholders to work together rather than as different parts?
You mean the patient organizations?
Yeah.
That's a very difficult one because a lot of associations they've become political in that they want to promote their own disease area. I think initiatives with related diseases, because they've been trying to get people who are involved, but it's still based on heart failure, with amyloidosis and what do you call it in English, postpartum.
Yes.
Cardiomyopathy.
Yeah, absolutely.
We'd actually kind of loosely work together, but with no kind of cohesion, or could I say administrative cohesion. And I think that there is a need for associations to work together, because I don't know about in the UK, but in France, we're generally seeing a decline in people wanting to become members of associations, because for various reasons, I won't go into them. But and I think we need strength in numbers, especially when we're talking about patient advocacy at European level or national level.
Yeah. Now, particularly to Francisco and Kamlesh, but also do come in, Angela. I want to know how in the US are you? What's the landscape in terms of research funding and implementation? Because we haven't set things up in the last few decades to do things across multiple long-term conditions. How are we going to do this without wasting time?
Sure. Well, it is not very good, but it's improving. The National Institutes of Health have right now, they are paying attention. They are sponsoring trials and studies that incorporate the multiple long-term conditions as part of the either target or populations to study, etc. There is still a lot of work to do, and part of the problem is the polypharmacy that goes along with the multiple chronic or long-term conditions, right? So, in the U.S., I haven't seen a particular interest or appetite to start working on polypharmacy and to start more minimalistic medicine where you focus on particularly the medications that will give the highest benefit. And I'm talking particularly in the very elderly patients above the age of 80 that take 20 medications. First of all, most of them are not taking those medications. Many are taking those in the wrong way.
Yep.
And many might be taking medications that are not relevant any longer, right? So I mentioned this because I think it is very relevant to address multiple chronic or long-term conditions from the scientific standpoint in how can we help those patients, but also that the help should not be necessarily just be on the what pills I add or what injections I increase.
Yeah,
right?
so actually there's some things that you might
Exactly
be able to
right.
stop and take
I mean,
away. Yeah,
technology is there to
Great
create poly pills, not just the poly pill as we know it, but the technology is there to create pills pretty much individualized to what you need, what he needs, what I need, what that patient needs, right? So taking a couple of pills a day that incorporate most of the medications that I need or that the patient needs, I think that's really the future. I mean, the technology is there. And this idea to manage 15 different medications every day, some of those 3 times a day, some of those once a day, it is totally crazy. And when we start practicing evidence-based medicine, we didn't anticipate that we will get to this nonsense of that.
One injection every month.
Yeah.
Kamlesh, how do we navigate the nonsense?
No. So the other one I think is in the terms of polypharmacy, I see this with my patients, is they get a different brand every 2-3 months. So it used to be a pink atenolol.
Yeah.
And suddenly it's changed to a different color because the patients don't remember the name of the tablets. I take the pink one in the
The
morning.
shape of the color.
Shape, exactly. And the shapes change. And so I think one thing we need to do really is get the shapes and the colors consistent with all of that. That'd be a simple step for people to take those medications. But stopping therapies, trying to make them much easier to take, fixed dose combinations, I think is a good idea. We don't use them in the UK as much, but you go to India, they've got 3 pills, 3 diabetes medications in 1 pill at a really low cost. And I think if we start doing simple things for patients, obviously there are apps to try and improve adherence, and all of these things together. And we've done systematic reviews showing there's not one intervention that'll work. You need multiple interventions to improve outcomes. In terms of just a question on the funding, I think we've been very fortunate in the UK. NIHR have been at the forefront of funding multiple long-term conditions research,
Including globally, isn't it?
globally. Yeah, 8 years they've been working on the UK and then the global centres that they've set up. As you know, you're part of the one we've got, multiple long-term conditions global health centre for that with India and Nepal. So and MRC are also funding that, but it's more basic science work. So I think UK has been at the forefront of multiple long-term conditions, including the terminology and the classification of multiple long-term conditions.
Thank you. And I want to finish up with Stephen and Angela. Training. So how do we, because I think we've also, even in people like yourself who have different conditions, you're also almost conditioned to think of them separately when you see this separate person and think about that because you're seeing a cardiologist today.
Yeah.
So what do we need to do in terms of training, education? Not necessarily from health professionals, could be from the wider public, could be more broad than that. And I'll come to you next about how we need to train people who are coming through us doctors, nurses, allied health professionals to be in this space as well? You first, Stephen.
You're talking about training healthcare professionals?
No,
or
training. I'm actually
patient
the kind of patient education awareness.
patient awareness. Okay. Well, I'm not sure if you have the same system in the UK. We have the system of educational therapy, where anybody, for example, who has heart failure and has other diseases, goes through a program of different workshops where things are explained. I don't like the word education because it's like kind of like teaching a dog new tricks. It's basically trying to give people support and information to empower themselves. And that is all important. Unfortunately, financially, we've got to find new models, because the problem in France is it doesn't have reimbursement status. So the person who has to travel to the hospital for this training doesn't get ambulance paid for, etc. So we're beginning to realize that, again, we come back to the community, is that all of this education has to go back out to the community and be local and not in the hospital. That the idea of the hospital has to change. The hospital is not four walls, it's the community round about us. And it is extremely important that people are made aware of and their disease, but also globally understand what the mix of all of these things could do, not in an attempt to sort of dramatize, but in an attempt to say, right, okay, this is how you need to deal with it to have quality of life.
Wonderful. Whether in Singapore or otherwise, are we training our health professionals to be ready in this space?
I would say that training health professionals might be a bit too late. So what we're doing right now in terms of prevention is really putting into community spaces, supermarkets, and food labeling, so that we don't really have to spend our time teaching students and medical students and doctors, but really starting from young, so that everybody in the community knows what healthy food is. There are now food labels in Singapore. So the amount of salt in the particular packet of food, there's a grading to it, the sugar, how much of that has saturated fats and so forth, and the calorie count. So that's happening in the community. And in addition, we are also trying to increase physical activity by really modifying our environment. So we've got environmental health districts, where every health district would have a certain exercise corner with gyms and all that. So I think it's more like trying to really, really go upstream. In fact, so upstream, we're even going to women who are pregnant, because those who develop gestational diabetes will then deliver the mother have diabetes when they grow older, the child may be at risk of childhood diabetes. So we're really, really going upstream all the way. And I think that is probably the future, the focus.
Okay. So I think we've had a very wide-ranging discussion. First of all, multiple long-term conditions is definitely the paradigm that fits with how our patients and how people are presenting to seek care in our health systems. So we must move in that direction wherever we are. That may need different ways of working. Some of that is technology enabled. Some of it is different ways of training. There's changes that are starting to happen in the landscape in terms of funding and so on. And this is obviously here to stay, and I hope that this is the first of many sessions that both World Heart Federation and other stakeholders have on multiple long-term conditions. I'd like to thank my panelists, but I'd also like to thank our sponsors, AstraZeneca, for supporting this session, the World Heart Federation. Thank you.
Thank you.
Well done. Well done.